All right, good afternoon, everybody. So it is my pleasure today to introduce today's speaker. We have with us Dr. Victoria Thompson. She's one of our Pediatric Endocrinology Fellows. She's doing her fellowship here with us at the University of Louisville. She completed her medical school at Pacific Northwest University and then came here to Louisville for her pediatric residency here at the University of Louisville and then stayed here for her fellowship. She is interested in health equity and is currently doing a very interesting project on that. But today she will be presenting on osteogenesis imperfecta, and she'll be talking about new perspectives and future therapies. So please join me in welcoming Dr. Thompson. All right.
All right. Well, thank you, Dr. Cabrera. I'm Victoria, and we're going to be talking about osteogenesis imperfecta today, looking at current therapies and then new studies on future treatment as well. So to begin with, I do not have any financial disclosures for this research or presentation, and most of the medications that we're going to talk about today are off-label uses. So to start with, our learning objectives today first are to define osteogenesis imperfecta, including pathophysiology and clinical manifestations. We're also going to discuss current treatment recommendations for osteogenesis imperfecta. The third objective is to review literature on new and emerging therapies. And then fourth, to discuss clinical implications of future therapies for the management of osteogenesis imperfecta. So as we go throughout this presentation, I'm going to use the term osteogenesis imperfecta and also the acronym OI to refer to osteogenesis imperfecta. So starting off, osteogenesis imperfecta is a genetic disorder characterized by brittle bones with other characteristics including blue sclera, short stature, dental abnormalities, and hearing impairment to various degrees based off of the type of OI and the severity of OI. Primarily, patients with OI have an autosomal dominant mutation affecting the encoding and production of type 1 collagen. Mutations in these genes are associated with structural and quantitative abnormalities. Less commonly for patients with OI, we see autosomal recessive and X-linked recessive mutations that impact processing and post-translational modification of this type 1 collagen. The incidence of osteogenesis imperfecta is between 1 in 10,000 to 1 in 20,000 individuals. And the severity, as we are going to talk about, depends on the specific mutations that we are looking at with osteogenesis imperfecta. So to begin with, I wanted to start talking a little bit about the history of OI. So if we go all the way back to the 1600s, this is when osteogenesis imperfecta was first described. Back in 1674 is the first time that we have recorded documentation of this disorder, and it was actually described by a French priest who was describing a 20-year-old who had significant fractures. And this 20-year-old was also described as having intellectual disability, which is not a characteristic that we see with OI. About 100 years later, a Swedish surgeon was further evaluating this, and he was the first one to use the term osteogenesis malacia when looking at a family that had 3 generations of individuals that had easy fractures. About 50 years later, in 1831, Edmund Axmann was the first one to start describing characteristics of osteogenesis imperfecta, and he described it with 4 specific characteristics there, looking at bone fragility, looking at hypermobility, easy dislocation of joints, and then blue sclera as well. Moving on to the 1850s, a Dutch professor by the name of Vrolijk first used osteogenesis imperfecta, and he was one that was able to look at the disorder and see that it was something impacting individuals from the age of infancy and that it was not an acquired disease later in life. As the 20th century progressed, it became clear to physicians and researchers that OI had a large clinical spectrum of disease ranging in severity from in utero or perinatal death to mild symptoms that may not be picked up in an individual until later in life. Further research and explanation of the spectrum of disease was done by three researchers, Silence, Sen, and Danks, and they were the first ones in 1979 to come up with the Silence criteria, which is how we classify osteogenesis imperfecta to this day. Their work used to describe osteogenesis imperfecta classified it into four different forms that we'll talk more about in this presentation. And since then, we have added on to these criterias and defined more forms of osteogenesis imperfecta. Into the 1970s and the 1980s, we learned more about this disease, with the 1970s being the first time that we were able to identify abnormal bone collagen under light microscope. And then the 1980s was the first time that we were then able to discover specific gene mutations and mutations in alleles of the pro-alpha-1 chain for collagen that was related to the genetics seen with OI. Going on to treatment, the 1980s and 1987 is the first time in the literature that we have reports of bisphosphonates, which are the standard of care for management at this time, being used in a 12-year-old girl with osteogenesis imperfecta. So getting into the genetics of OI, osteogenesis imperfecta is inherited primarily in an autosomal dominant form. Autosomal recessive and X-linked recessive inheritance occurs less commonly. The most common forms of OI that we see are mutations in the COL1A1 and COL1A2 genes. Mutations in these genes specifically affect glycine substitutions that we see in the triple helix of collagen. This impacts the form of the type 1 collagen and changes its strength. Genetic mutations can be a result of both quantitative or qualitative defects when we're looking at this type 1 collagen, and the autosomal dominant forms that we see oftentimes affect the glycine substitutions. When we're looking at autosomal recessive forms of OI, we see that these and the X-linked forms as well oftentimes impact post-translational modification and then impact the structure and function of collagen from this aspect. Looking more at type 1 collagen here, and in the two images here that we have on the screen, we know that type 1 collagen is the primary protein that makes up skin, bones, tendons, cartilage, teeth, and forms as a scaffolding for these structures. Type 1 collagen is made up of two pro-alpha-1 chains and one pro-alpha-2 chain. Within this collagen, we see that there's an amino terminal propeptide, a central terminal propeptide, and then a carboxyl terminal propeptide. What's essential to the structure of collagen is that glycine is going to be found in every third amino acid, which is going to lead to the formation of the triple helix. Mutations in this collagen, specifically frame shift mutations or premature stop codons, can result in quantitative decrease of the amount of type 1 collagen that is formed. These mutations are commonly what we see in the autosomal dominant form of OI. Errors in substitution can also impact collagen formation, leading to abnormal collagen that's formed, impacting the strength. What we see specifically with these different forms of OI is that the location where these substitutions or deletions occur is going to impact the severity of disease that we're looking at. The earlier the substitution or the deletion occurs, and this is going to be closer to the carboxyl terminal end of the polypeptide, the more severe of clinical manifestation that we're going to see. We'll talk about this more specifically in the following slides, looking at OI type 2, type 3, or type 4. There's some rare recessive mutations that have been found more recently looking at disease, and these are going to impact the assembly of the triple helix. So before we go on and talk about the abnormalities seen in osteogenesis imperfecta, I wanted to review some of the normal steps of bone physiology and maturation and how impacts in the formation of type 1 collagen impact healthy bone. So the cartilage matrix is a very important part of healthy bone physiology. Osteoid, or that bone matrix, is made up of type 1 collagen and ground substance as well. So bone formation is going to occur as a result of both intramembranous ossification and endochondrial ossification as well. And in this image, we're going to talk about the formation of endochondrial ossification. So to start with, here on the slide, endochondrial ossification is the process by which mesenchymal cells are going to differentiate into our chondroblasts and are going to produce a collagen matrix. We can see that here in these first two depictions of bone on the left of the screen. The periosteal collar is then going to start to form around the bone as well, and this is going to be formed by the osteoblasts shown in this image. In the center of the diaphysis, you're going to have chondroblasts that start to hypertrophy, the cartilage is going to become calcified, and then blood vessels and connective tissue cells are going to start to form the bone marrow cavity that we see in this next image here. The trabeculae, or the calcified cartilage, are then going to remain at the two ends of the bone here. These are the secondary ossification centers, with the primary ossification center being in the center. In individuals with osteogenesis imperfecta, we see delayed periosteal bone formation. We also see increased activity in bone resorption that is not matched by new bone formation. So to further investigate these differences, we're going to move on to this next slide where we're looking at x-rays and histology specimens from an individual with OI. So starting here first with the x-ray images, both of these images come from an infant who died of complications of type 2 osteogenesis imperfecta a few weeks after birth. First, when we're looking at the bone morphology here on the left, we see that the structure of the bone is impacted. The microarchitecture of the bone and multiple fractures are present in these femur specimens. When we move on to the histology here on the right, we have the periosteum at the top, we have woven bone, and then we have the bone marrow below. What we see with the woven bone here is that it's discontinuous, and the large marrow cavity below lacks the presence of normal trabecular bone, which ultimately impacted the structure and function for this infant. Moving on here, we have histology slides as well, looking at a patient with osteogenesis imperfecta versus normal bone. Our normal bone is going to be in this column here on the left, and then our osteogenesis imperfecta slides are going to be here on the right. When we're looking just generally at these slides, we can see that individuals with OI lack the normal structure that those with normal bone have. And moving specifically down to these two bottom slides here, this left being normal and this right being OI, what we see with this is in the left, we have normal trabeculae and we have normal bone marrow between the trabeculae, versus here on the right, the bone is much more fibrotic. It's irregular, it lacks the normal trabeculae, and then it also lacks the normal marrow between the trabeculae as well. When we're looking at the formation of collagen as well, there are many different genes that are important in type 1 collagen formation. There are dozens of genes that have been implicated in osteogenesis imperfecta, and those are outlined at the top of the slide here. So at the top of the screen, we have different genes that are important in type 1 collagen formation. Here, starting at the left, the genes that are shown in gray are involved in signal transduction and gene expression. Moving down to the genes here in brown, these are important in translation. Our red genes up here are important in post-translation modification. And then moving on to our genes further on here, these are important in proteolytic processing, and then green in bone mineralization. So defects in any of these genes can impact the formation of collagen. So when we're looking at the formation of type 1 collagen, first we're going to see nuclear translocation of transcription factors and alpha 1 and alpha 2 chains of the type 1 collagen that are then going to go to the rough endoplasmic reticulum for transcription. Molecular chaperones are going to be very important for the folding of type 1 collagen and forming that triple helical structure. This structure is then secreted as a procollagen with a coat protein complex that is then going to traffic it to the Golgi for further processing. When it arrives here, both N and C propeptides of the procollagen are going to be cleaved off, and it's going to be secreted then to be able to be cross-linked and mineralized with other proteins that are going to form that extracellular bone matrix. So looking at all the other genes in the other slide that we were looking at here, this is where these genes come into play with the various forms of osteogenesis imperfecta. So this slide, and I know the font is very small on this, but this is looking at types of OI based off of the silence criteria. So the silence criteria that we looked at earlier classified the first 4 types that are seen. This table has up to 5 types of OI that are classified, and this is from 2021. And since then, we've been able to identify over 8 different forms based off of specific gene mutations that have been found. So moving through the types of osteogenesis imperfecta, the first type that we have is type 1. This is described as a non-deforming form, and it's going to be our most mild form of osteogenesis imperfecta that we see. Most of the mutations that are going to lead to this form of OI are going to be autosomal dominant in nature, and less commonly, they're going to be X-linked. With this form of osteogenesis imperfecta, what we see is that the mutations are going to result in about a 50% reduction in the amount of type 1 collagen that's formed. The mutations can lead to frame shift, nonsense, or splice site alterations, and ultimately this is going to lead to mRNA instability and haploinsufficiency. When we're looking at the clinical manifestations of this disease, certain individuals with type 1 OI can go for a long time without being recognized or diagnosed. Other individuals are going to have increased bone fragility, they're going to have blue-gray sclera, and they also sometimes are going to have their final adult height impacted. Oftentimes, they're not going to be less than -2 standard deviations from the general population, but they may not be at the genetic potential that they have. These individuals oftentimes also are going to have conductive hearing loss, which can become sensorineural and is progressive in nature, and they oftentimes have hypermobile joints as well. This is a more mild form of disease. These individuals oftentimes are not going to have respiratory or neurologic complications associated with their form of OI. Moving on to type 2 OI, this is the most severe form of osteogenesis imperfecta and is described as perinatal. What we see with type 2 is that oftentimes this is going to be a perinatal lethal form. Death can occur in utero or a few weeks after birth as a result of this condition. Type 2 also can be autosomal dominant, but we can see autosomal recessive inheritance patterns as well, with specific subclassifications that we can identify more to look at whether this is perinatal lethal or we can expect to see severe complications affecting the infant after birth. With these individuals, congenital fractures oftentimes are seen, and the most common cause of death as a result is going to be respiratory compromise. Type 1 collagen is also very important in lung tissue as well. So in addition to significant fractures that are seen, it can also impact oxygenation. These individuals oftentimes have hypermobile joints as well, and have very dark blue sclera. Type 3 osteogenesis imperfecta is not as severe as the previous type that we were talking about with type 2, but it's a progressively deforming form of OI. It can be from moderate to severe in nature and is also inherited in autosomal dominant or autosomal recessive inheritance pattern. With these individuals, they also have the blue-gray sclera. They can end up very short and are going to be at about the height of a prepubertal child. Congenital fractures are commonly seen in these individuals. They oftentimes will have hearing loss, and respiratory or neurologic complications are very common. Type 4 OI is described as a moderate form. So these individuals also autosomal dominant, autosomal recessive inheritance pattern. They're going to have the blue-gray sclera. They're going to be a little bit taller than the kids that we are seeing with type 3 osteogenesis imperfecta. Oftentimes, these individuals are going to have hearing loss, about an incidence rate of 42%, and they oftentimes will have hypermobile joints as well. The last major classification that we're going to look at is type 5 osteogenesis imperfecta. This is primarily autosomal dominant. It's moderate in severity with a lot of the similar features that we've talked about in the previous ones, except they're not going to have the differences in the color of their sclera. And then a quick overview about some of the newer forms of osteogenesis imperfecta that we are identifying. Type 6 through 8 are all autosomal recessive in nature, moderate to severe, with type 8 being the most severe and being perinatal lethal in nature. Most of these we have genetic mutations that have been associated with it, but some we're still learning significant amounts about them. So to visually look at how we can see the differences between type 1 and type 4 osteogenesis imperfecta, I've included this image here, which is from a clinical trial looking at adults where they did whole body scans of individuals with various forms of osteogenesis imperfecta. The age of the adults in this study were anywhere from 27 to 63. And as you go from left to right here, we have these two individuals have type 1. These two individuals have type 4, and then the individuals to the right here have type 3. So when we start at looking at the whole body scans of the individuals with type 1, the individual furthest on the left did not have significant complications or clinical manifestations of disease. The individual here to the right with type 1 had kyphoscoliosis and had more short stature related to the disease. And as we progress to the right, you can see the increasing severity. So this third individual right here actually had bilateral lower extremity amputations as the result of very severe lower extremity fractures at a young age. And then this individual here next to them is a 35-year-old female. She had rods that were placed in her lower extremities in both her femur and her tibia due to the severe deforming form that she had there of her long bones. As we move here to the right, we're seeing more severe disease. So this is type 3. We have a 27-year-old here, and then we have a 40-year-old here. And in addition to seeing significant long bone deformities and significant short stature, we have severe degrees of scoliosis, the kyphoscoliosis that are present here, significant bone deformities of upper and lower extremities. This individual here, furthest to the left, has a placement of a rod in their right upper extremity. And then even looking at the bone structure and formation here, we can see that the epiphyses are significantly impacted in these individuals. And it's described as popcorn epiphyses from the way that it looks in imaging and the significant alterations that we see in normal function. And then as we're talking about some of these physical exam findings in the different forms of osteogenesis imperfecta, we're talking a lot about blue sclera. The reason that we see this in kids and adults with OI is that type 1 collagen is a primary protein that's seen there in the sclera. And so without that, the sclera becomes more translucent and you're able to see more of the blood vessels there behind the eye, which is going to give it that blue tint. When we're looking at the teeth as well, type 1 collagen is important in tooth formation. So as with the rest of the bones, the teeth can become more brittle, they can break easier, and then you can be more at risk for fractures as well. So let's start talking about management and current therapies of osteogenesis imperfecta that we're talking about with our patients that we see in clinic. So the current guidelines in treatment of osteogenesis imperfecta are guided by the principles of maintaining function, preserving bone mineral density that is there, and then treating complications of osteogenesis imperfecta. So treating hearing loss, treating dental abnormalities, and providing respiratory support as needed for individuals that have these complications. To start with maintaining function, what we can see, especially in individuals who are impacted by osteogenesis imperfecta at a very young age, is that they can go to avoid doing certain activities, doing movement, doing weight-bearing activities. And as a result of this can impact their motor development. This can impact their muscle formation. This can impact the amount of weight-bearing activity that they're doing. So getting them into physical therapy can be really important in maintaining the muscle strength that they have and encouraging weight-bearing activity to the ability that they're able to do it. This is also going to help increase their joint stability and maintain and increase function that they have. Bracing also has been shown in some of these individuals to help with supporting the joint functionality, to help with the supporting of weak bones, and it can decrease pain with movement in some individuals as well. When we're talking about preserving bone mineral density, our gold standard of treatment right now in osteogenesis imperfecta is the use of bisphosphonates. The goal of bisphosphonates is to help preserve bone mineral density and to help decrease fracture risk, although the literature on this has not proven specifically that we've seen significant impact in this improvement. IV bisphosphonates are the treatment of choice over oral bisphosphonates because IV bisphosphonates are going to have less of the GI side effects. And three of the most common ones that we see for treatment are going to be IV pamidronate, IV zoledronic acid, and IV neridronate. The goal of bisphosphonate use is to decrease high cell turnover and to increase new bone formation. When we're looking at this new bone formation, though, we know that we're still looking at new bone formation with type 1 collagen that is not at its full strength. And so the goal is to increase the amount of bone that's formed, but it's still going to be brittle bone that forms. Most of the studies that are out on the use of IV bisphosphonates in children are with the use of IV pamidronate. And the studies have shown increase in lumbar spine bone mineral density, increase in hip bone mineral density, and the biggest changes that have been seen with this are within the first 6 months to 12 months of treatment. There's very variable evidence, though, when you look at the literature in terms of changes of fracture rate for these individuals. And then for individuals receiving IV bisphosphonates, there's no significant evidence that shows an impact on their final adult height for individuals taking it or on a decrease in bone pain. In addition to IV bisphosphonates, we want to support overall bone health as well. So we have goals when we're looking at our vitamin D dosing and for calcium supplementation as well. So when we're looking at vitamin D supplementation, our current goal is a goal 25 hydroxyvitamin D to be greater than 30 to promote good bone health. In addition to this, we follow calcium supplementation based off of the RDA for age, which as you go, you see 700 milligrams daily is recommended for kids under the age of 3, increasing to 1,000 milligrams before puberty, 1,300 milligrams during puberty, and then 1,000 milligrams daily for adults less than the age of 50. When we're looking at the dosing of our bisphosphonates as well, the way that we dose them for our pediatric patients with osteogenesis imperfecta is primarily with zoledronic acid. The reason for this is IV zoledronic acid can be given as an infusion that occurs over 1 day. When we dose it, we initially dose it every 3 months. We then space it out to every 6 months and then yearly, knowing that the biggest impact that we see on increasing that bone mineral density is there within the first year of treatment. IV pamidronate is another option of choice, but this is an infusion that has to be infused over 3 days sequentially, and then can be administered every 2 months, every 3 months, or every 4 months based off of the patient's age and the severity of osteogenesis imperfecta. Other management considerations that we think about for these kids are making sure that they get yearly hearing screens, specifically based off of the form of OI that they have and then the risk that they have of hearing loss. It's very important for these kids also to have close follow-up with dentists given the risk of brittle teeth. Crowns and other assistive devices have been used to help individuals who have frequent fracturing of teeth. In individuals with more severe osteogenesis imperfecta, it's important to look at lung function as well, because we know that these individuals can have significant scoliosis, but also changes in the lung tissue that's going to impact their oxygenation. So with these kids as well, we'll talk more about screening that we do with pulmonary function testing. And then finally, orthopedics plays a very important role for these individuals too. So orthopedic surgeries are considered for correction of long bone deformities, and they can use telescoping rods in individuals who haven't reached their final adult height so that these rods can extend with growth. And finally, for kids with OI and for adults with OI as well, we know that these individuals are going to be at increased risk of valvular cardiac disease. So we're looking specifically at mitral regurgitation, tricuspid regurgitation, and then other cardiac manifestations as well, including heart failure, aortic dilation, and then pulmonary insufficiency. So the current recommendations are really just current recommendations that you would see for any individuals that you're seeing in clinic. The questions that they use to guide treatment are questions about whether an individual is having shortness of breath, whether they're having any chest pain, recommendations for a yearly blood pressure evaluation, and then we obtain a baseline echo, EKG, and pulmonary function testing for these individuals if they're having any symptoms. The frequency of following up these images are really based off of findings that are seen on that initial imaging and then persistent symptoms that these individuals are having. There are not great guidelines right now out on the frequency of echoes to obtain based off of the type of OI or the frequency of pulmonary function testing either. So as we see that bisphosphonates have been well studied in both children and adults, a lot of the results that we are seeing are not satisfying. These kids and adults are still fracturing, and we don't currently have a treatment for osteogenesis imperfecta. So in this next section of the presentation, we're going to talk about some studies that are being done to look at other medications and treatment for OI. As we start to look at these studies, a lot of these studies are done on very small population numbers. Some of these are case reports, some of these are done on 8 to 10 patients at a time. And oftentimes the patients that they are looking at are patients who have failed other therapies or have very severe forms of osteogenesis imperfecta. The first medication that we're going to talk about is Denosumab, which is a monoclonal antibody. The reason that it is looked at in osteogenesis imperfecta is due to its anti-bone resorptive effects and the studies that have been done in osteoporosis in postmenopausal women, specifically from the mid-2010s. So Denosumab is an IgG2 human monoclonal antibody. It reduces bone resorption and it's going to increase bone mineral density as well. The way that it works is how it impacts rank ligand. So rank ligand is going to play an important role in differentiation and survival of osteoclasts. By denosumab binding to rank ligand, it's going to inhibit rank ligand interacting with its receptor rank, and thus the goal is to decrease osteoclast survival and differentiation. Case reports that have looked at this medication have shown improvement in bone mineral density, decreased bone pain, and improved quality of life. And these are reports that have been published between 2012 and 2019. However, a new study published in 2024 evaluating individuals on denosumab and then individuals receiving IV bisphosphonate therapy with zoledronic acid showed that both groups showed an increase in lumbar spine bone mineral density, but the individuals who were receiving denosumab had an increased risk of hypercalcemic crisis and ultimately were switched back over to zoledronic acid. So our studies currently have very small populations and also have concerns for significant risks that could be associated with this medication. The next medication that we're going to talk about is Teriparatide. This is an osteoanabolic agent. It's a fragment of parathyroid hormone, and it's been used in the treatment of adults with osteoporosis. The way that this medication works is it's a pro-osteogenic factor. It's going to impact factors like FGF2 and IGF-1, and it's going to increase the expression of transcription factors that are involved in the differentiation and the survival of osteoblasts. Teriparatide is also going to have some of the similar impacts that we see with PTH in terms of increasing serum calcium and decreasing phosphate. In one double-blind, randomized placebo-controlled trial looking at patients with an average age of 41 who were receiving teriparatide, they showed significant increase in bone mineral density and decrease in bone turnover labs for individuals who received this medication and were followed for 18 months. They saw significant improvements specifically for individuals with type 1 OI versus type 3 or type 4. So it was seen to have more benefit in those with milder disease. The next classification of medicines that are being looked into at this time are sclerostin inhibitors. So sclerostin is going to be a glycoprotein. This is secreted by osteocytes, and it negatively impacts osteoblast differentiation, negatively impacts bone formation, and then it also is going to impact bone mineralization as well. So one of the medications that is being looked at this time is Denosumab, and this is a monoclonal antibody that is going to neutralize sclerostin. And by doing that, the goal is to increase osteoblast production, increase production of factors that are important in bone formation and factors that are important in bone mineralization. So again, this is another medication fitting with the other classes of medications that we have seen that have been looked at in postmenopausal women with osteoporosis. And the results from small phase 2 trials that have looked at this inhibitor in adults with moderate osteogenesis imperfecta showed increase in bone mineral density, decrease in bone resorption, and stimulation of new bone formation as well. There are 2 different case reports that I looked at too, and again, these are very, very small populations and individual case reports of individuals in the ages of between 50 and 60 who received sclerostin inhibitors for 1 year and had significant change in bone mineral density. When we're looking at sclerostin inhibitors, there are also studies that have looked at these in pediatrics as well. And a specific monoclonal antibody, Setrusumab. This is a sclerostin inhibitor, and this has been studied in pediatrics in a phase 3 clinical trial. The trial is currently ongoing, and its goal is to look at the impact of this monoclonal antibody versus IV bisphosphonates that kids are receiving for OI. And the goal is to look at changes in fracture rate in these 2 populations receiving these 2 medications. Patients who are currently eligible for this have type 1, type 3, or type 4 OI, and it's currently being done at 20 different study locations across the United States. Other medications that are being looked at right now are looking at inhibition of TGF-beta. In studies looking at children with osteogenesis imperfecta after and post-mortem samples and evaluation of the bone, what they saw is that these individuals compared to controls had increased TGF-beta signaling, which is what led to the evaluation of looking at these treatments. This is very early in studies. They have looked at mouse models that have shown increased TGF-beta signaling as well, with improvement in bone mineral density and strength when they've received TGF-beta inhibitors. And we have a monoclonal antibody as well that's under current phase 1 trial in adults with osteogenesis imperfecta. So with this study, they've looked at escalating doses of this monoclonal antibody and have looked at it specifically in individuals with type 3 and type 4 osteogenesis imperfecta. In those with type 4 OI, they found a robust response in their bone mineral density, but this was not shown in those with type 3 OI, and they actually had a decrease in their lumbar spine bone mineral density. Again, this trial is impacted by the limited sample size that they're able to look at when evaluating these medications. The last 2 that we're going to look at are cell therapies and gene therapies. So cell therapy right now is targeting the mesenchymal stem cells. This is a new area of research in patients with osteogenesis imperfecta. And this is because the mesenchymal stem cells are present in bone marrow, and they have the capability to be able to differentiate into osteoblasts as well as other bone lineage cell types. Cell therapy has been evaluated in patients with severe osteogenesis imperfecta who have failed other treatments, and specifically in type 3. Early studies, and these are very early studies though, have demonstrated success. And by success, they've showed decreased fracture rate, and they've been able to identify cultured osteoblasts that have been present in the bone marrow of these individuals who have received the cell therapies. So looking at cell therapy, one of the benefits of it is that these individuals do not require the need for immunosuppression. Cell therapy has been studied in allogenic transplants, and these patients receive stem cell infusions from HLA-matched siblings. To look specifically at cell therapy, there's one clinical trial that looked at cell therapy used in 2 individual pediatric patients with osteogenesis imperfecta. This clinical trial was done over 2.5 years and was used to assess the safety and the effectiveness of repeat infusions of histocompatible mesenchymal stem cells in these patients. These individuals had moderate to severe OI at the beginning of treatment. So both of these patients received 5 infusions of stem cells from an HLA-matched sibling. They received them every 5 to 6 months, and they received them over the course of 2.5 years. For these individuals, they tolerated the infusions very well. There were not significant side effects, and they saw a decreased number of fractures during the timing of the study and then for 2 years after the infusions were completed in follow-up. Bone mineral density they saw starting to increase after the second infusion, and this continued throughout the trial. And then these individuals also reported improvement in parameters, including quality of life and bone pain as well. And then finally, we're going to talk about gene therapy. So gene therapy is under investigation as well, specifically looking at targets in some of the most common gene mutations that we see. So the COL1A1 and COL1A2 that we were talking about earlier. The difficult thing with osteogenesis imperfecta is that there are over 800 mutations that have been identified for individuals with this spectrum of disease. And so looking at gene therapy, there are limitations in the variety of patients that we see and the number of mutations that are seen as well. Initial investigation was started in 2004 when adeno-associated virus was used to target the COL1A1 gene and replace missense mutations in 2 different patients. It was able to successfully target these abnormalities and was found to be successful in these 2 patients with OI. They then found that these individuals were able to produce normal type 1 pro-collagen and were then able to produce normal type 1 collagen. But again, these studies are very early, and we have to look at the applicability when we have the variety of presentations that we do in OI. So in conclusion, osteogenesis imperfecta is a very broad spectrum of disease in which it can be very debilitating, it can be life-altering, and we really don't have any definitive treatment for this disease at this time. There are limited options for management, and there's need for further investigation in terms of other forms of management for these patients to increase bone mineral density, improve quality of life, and to decrease their bone fractures. These are the sources that I used in this presentation. And here is the event code as well today.
Yes.
Can I ask a few questions?
Yeah.
And thank you. That was a very clear talk, and the slides were in.
Okay.
I followed you all the way. Most of the way. So one question I have is now, this is an autosomal dominant, so there's usually, although apparently there are some recessive also, and if different genes can be affected, and that's going to affect how it's going to be manifested. So does that mean that if one partner has that gene, the patient will always get that? Or the offspring will always get that?
If it's autosomal dominant, then it'd be about a 50% chance. And so we see individuals where one parent has it, maybe a grandparent has it, and they can trace it back in their lineage as well. Like, oh yeah, I know grandma had like blue eyes, or she had all these fractures.
But didn't he have a severe disease, or maybe die young?
And it depends on the severity. When we're looking at type 1, and that's the most common form that we see, oftentimes it's a more mild presentation. So the children that we can see, maybe they've had 6 or 7 fractures by the age of 10, and their parents might have as well.
Right. So I don't know, I guess if it's pretty mild in one person, it would be mild in the next offspring because it's the same.
Not always. It can have varying degrees of like severity or presentation.
Because, since it seems like it would be fairly easy often to pick it up, and can't they do amniotic fluid testing to see if the fetus has that?
And they can do testing to see if the fetus has it too, but some individuals aren't diagnosed until a later point in life. And if they had a mild disease, they may not know about it until later.
But you would think that if you had a big effort to identify this, then you could kind of like Tay-Sachs disease and eventually pretty much eliminate.
Yeah. If we could get all the early screening and identification.
And now, but it's really the collagen that's at fault, but there doesn't seem to be any treatments for the collagen.
Yeah. And our options for treatment are still very limited. Yeah. Yes. Yeah.
I agree 100%. The slides were very clear in your presentation. I wanted to ask you, because there aren't good pharmacologic treatments right now to get at the mutation or to get at the collagen. You mentioned some non-pharmacologic treatments like calcium and vitamin D optimization, physical therapy, movement. Have you seen anything about the role of metabolic surgery in these patients? Because they're limited as far as their ability to really be active with weight-bearing activity, running, biking, jumping, can cause fractures. And I asked this for curiosity, but also because I have 2 ladies that I follow in my clinic, a mother and a daughter. And the daughter, the younger one, just underwent metabolic surgery, and her physical function has improved so much. Have you seen, or did you see when you were preparing anything about that in the
That's a really good question. And when I was preparing, I didn't see anything specifically about metabolic surgery. But I should go back and look into that more and see if there's much published, because we know that these individuals are so limited by the amount of activity that they can have. But if they have significant obesity, that also is going to impact their function as well too. So